Hi there, my name is Mike Pishvaian. I'm an associate professor at Johns Hopkins University, and it's my pleasure today to talk about the relevant updates in GI cancer from ASCO 2023, incorporating some of the data that we've also seen throughout the year. I'm going to talk a little bit about some of the targeted therapies and some of the more practical aspects of caring for patients with GI cancers that have come up in the last roughly 12 months. The management of locally advanced rectal cancer has been a fairly well-established paradigm since 2005. And I think a lot of the updates that I'm going to talk about in a second have been smaller permutations, but we really don't know what the quote unquote right thing to do is for this disease. So let me walk through this. And this was actually presented in a slide by Deb Schrag at ASCO 2023 in the context of the PROSPECT study. And I think it sets the framework well. So prior to 2005, of course, the standard of care was was initially surgery alone, followed by surgery and then radiation, and then also chemotherapy. And surgery followed by chemotherapy clearly improved overall survival as well as local recurrence rate. In 2005 was a paradigm establishing SARA study in which they compared preoperative chemoradiation to postoperative chemoradiation, but all patients had surgery for their locally advanced rectal cancer. And what was found was that the preoperative chemoradiation generally was better tolerated. It led to less surgical complications and at least a higher intent for sphincter sparing surgery. In other words, no colostomy bag after surgery. So that became arguably the standard of care, where we were giving pelvic chemoradiation with 5-FU or capecitabine along with along with radiation therapy concurrently for about 5.5 weeks. Patients would then recover, they would get surgery. And then there was a lot of debate about whether or not we would give adjuvant chemotherapy. There was technically no randomized phase 3 trial in this scenario that proved that we should give adjuvant chemotherapy, but most of us did, sort of following along the colorectal cancer adjuvant therapy or the colon cancer adjuvant therapy data. But this paradigm raised several questions. What kind of radiation would be ideal? Should it be short course or long course? Could more or all of the chemotherapy be given preoperatively? Could surgery be avoided altogether in the watchful waiting or non-operative management approach? And as was explored in the PROSPECT study, could radiation therapy be avoided? And unfortunately, there's really no absolute best management of locally advanced rectal cancer. In fact, if you look in the guidelines, the guideline-based decision process is really establish how your local center would do it and develop some expertise in that. So choose as a group how you're going to treat your locally advanced rectal cancers and then move forward with that. And really, many of these decisions are now needing to be made on a case-by-case basis, taking into account the particular wishes and priorities of the patient, the specifics of the tumor, particularly the location, high or low within the rectum, and then move forward with that. So with that background, there were a couple of important studies that were updated / presented at ASCO 2023. I'll start with the PRODIGE 23 study, which was an update of what they called total neoadjuvant therapy with modified FOLFIRINOX versus preoperative chemoradiation, sort of the standard approach for locally advanced rectal cancer. The reason I say TNT kind of in quotations is because patients still all received adjuvant chemotherapy for up to 3 months. So it wasn't truly total neoadjuvant therapy. It was total neoadjuvant systemic therapy with the full dose modified FOLFIRINOX. So this was the study. Patients with localized rectal cancer, T3, T4, or any involvement of lymph nodes were enrolled. There was a fairly large number of patients, 461. They were randomized to what was arguably the standard of care when this study was designed. Again, preoperative chemoradiation, followed by surgery, followed by up to 6 months of either FOLFOX or capecitabine at physician's discretion. In the TNT arm, patients received 3 months of modified FOLFIRINOX, followed by radiation therapy with chemo with capecitabine, and then followed by surgery and up to 3 months of modified FOLFOX or capecitabine. So it was really a peri-adjuvant regimen. And in the updated presentation by Dr. Conroy at ASCO 2023, what was shown was that all endpoints were improved when the patients received modified FOLFIRINOX initially. The 7-year disease-free survival rate was greater. The 7-year overall survival rate was greater. And importantly, for looking at patients who might develop metastatic disease, the rate of metastatic disease was actually much higher for patients who received the standard of care chemoradiation followed by surgery, followed by radiation, by chemotherapy. So really, all metrics suggested that we should be giving full dose systemic chemotherapy before surgery, maybe before chemoradiation, and that's what the next trial is going to discuss as well. So that's where the prospect study came in, to ask whether or not we should be giving radiation therapy. The prospect trial, again, was designed at a time when preoperative chemoradiation was the standard of care, followed by surgery, followed by chemotherapy. And in that context, the question really was, do all patients need radiation? Could some patients be cured without the need for pelvic radiation because chemotherapy seems to be so effective? In this trial, patients were randomized to receive the standard chemotherapy, chemoradiation, or they received FOLFOX. I'll note for you here that when this study was designed, it was FOLFOX, not for FOLFIRINOX. So based on the PRODIGE 23 study, perhaps this actually would be improved further if it was FOLFOX. In any case, patients were treated with preoperative chemoradiation or with FOLFOX. The patients who received FOLFOX were then restaged by MRI. And if there was a greater than 20% response rate in the tumor, patients then went directly onto surgery. They did not receive radiation therapy. This 20% response rate, Dr. Schrag addressed specifically in her talk. It was essentially a consensus best endpoint to go for. There was really no data to know that that's the prime endpoint to go for, that they made a decision as a group that they wanted to see at least a 20% response in the tumor. If there was no response or less than a 20% response, then patients would get chemoradiation followed by surgery, followed by adjuvant chemotherapy. So these were the long-awaited results of a relatively large study that was done over 10 years. The disease-free survival rate, which was the primary endpoint, was non-inferior, was the same for patients who received chemotherapy up front and used radiation only on a selective basis. And similarly, the overall survival was also non-inferior to receiving FOLFOX and selective chemoradiation first. In the trial, only 9% of patients in the total neoadjuvant therapy arm or the preoperative chemotherapy arm receive radiation. So another way of saying that is that 91% of patients were spared radiation therapy in the TNT arm. Interestingly, the pathologic complete response rate was similar between the two arms, whether they got radiation therapy or they did not. So even though only 9% of patients in the TNT arm actually got radiation therapy, the path CR rate was exactly the same, very, very similar, suggesting that most of the work being done in the treatment in the preoperative treatment for rectal cancer was really being done by the chemotherapy, not by the radiation therapy. So this trial and the PRODIGE 23 trial has started to put things into focus a little bit more. First of all, I think the question of watchful waiting is something that needs to be considered for every patient, because some patients say there's no way I'm going to have surgery and be left with a colostomy bag. But there are also some patients that say, of course you need to cut this thing out of me. Do what you need to do preoperatively, but get rid of the cancer ultimately. And that's part of the decision-making process. If you're going to go for a watchful waiting approach, things like path CR become more important. There are data to suggest that long course radiation might be more compatible with a watchful waiting approach than short course radiation therapy. So it's something to be taken into consideration. Similarly, if you have a patient that wants to get that wants to avoid preoperative radiation, particularly for the potential complications on the rectum, on the bladder, on other organs, then maybe using this approach might be better as well. I think how I'm adopting these data sets into my practice is that, first of all, I'm actually using chemotherapy, full dose chemotherapy, whether it's FOLFOXIRI or whether it's just FOLFOX/KPOX. I'm incorporating full dose chemotherapy into the preoperative management of these patients routinely. decisions about radiation therapy really come down for me, and this is not data that we have yet, as to whether this patient might want to consider a watchful waiting approach. Because if they do want to consider a watchful waiting approach, then I would probably recommend that they get a long course of radiation therapy as a planned part of the treatment. However, if patients want to avoid radiation therapy, then I might be inclined to do the chemotherapy first and just reassess and have them go on to surgery.